Radiofrequency ablation, RFA, is an endoscopic ablation technique for safe and effective eradication of Barrett's esophagus containing early neoplasia. In patients with visible lesions, radiofrequency ablation can be safely and effectively preceded by endoscopic resection of these focal lesions, yielding a specimen for histological staging and rendering the mucosa flat prior to RFA. Multicenter studies have reported complete eradication of all intestinal metaplasia and neoplasia in 77 to 100% of patients after RFA, with or without endoscopic resection. Radiofrequency ablation treatment usually starts with a circumferential ablation with a balloon-based Halo 360 device, followed by focal ablation sessions with a smaller Halo 90 device to treat residual Barrett's esophagus. Generally, 3 endoscopic RFA sessions are sufficient to achieve complete conversion of the Barrett's esophagus into squamous mucosa. Despite the good results of radiofrequency ablation treatment, sporadically patients demonstrate a poor response to this treatment. In 5 prospective radiofrequency ablation studies, Vilsteren et al. Examined 6 patients, 4%, in whom the RFA treatment protocol failed to achieve complete removal of all intestinal metaplasia and or early neoplasia. In these patients, the median percentage regression of the Barrett's epithelium 3 months after the initial circumferential radiofrequency ablation treatment was 35%, compared with 90% for other patients. The authors therefore hypothesized that there was a small subgroup of patients that demonstrates minimal regression of the Barrett's epithelium 3 months after the initial circumferential RFA, and that in some of these patients, complete eradication of Barrett's esophagus will not be achieved despite repeated RFA sessions. The early identification of patients with a high chance of failing RFA may influence the choice between RFA and other endoscopic treatment modalities, such as complete stepwise endoscopic resection, a conservative approach with regular endoscopic follow-up, or surgery. In this multicenter study entitled Predictive Factors for Initial Treatment Response After Circumferential Radiofrequency Ablation for Barrett's Esophagus with Early Neoplasia, a prospective multicenter study, Vilsteren et al. Prospectively collected baseline factors relating to patient characteristics, features of the Barrett's segment, and technical aspects of the circumferential RFA procedure, and subsequently related these factors to the regression of the Barrett's esophagus surface area 3 months after CRFA to identify potential predictive factors for initial treatment response after CRFA. Here is a summary of the study. Background and study aims. Radiofrequency ablation, RFA, is safe and effective for the eradication of neoplastic Barrett's esophagus. However, occasionally there is minimal regression after initial circumferential balloon-based RFA. This study aimed to identify predictive factors for a poor response 3 months after CRFA and to relate the percentage regression at 3 months to the final treatment outcome. Methods. consecutive patients from 14 centers who underwent CRFA for high-grade dysplasia at worst were included. Patient and treatment characteristics were registered prospectively. Poor initial response was defined as less than 50% regression of the Barrett's esophagus 3 months after CRFA, graded by 2 expert endoscopists using endoscopic images. Predictors of initial response were identified through logistic regression analysis. Results. There were 278 patients included. Median Barrett's segment C4-M6. In poor initial responders, N is 36, 13%, complete response for neoplasia was ultimately achieved in 86% as against 98% in good responders, and complete response for intestinal metaplasia, CRIM, in 66% as against 95%. Poor responders required 13 months treatment versus 7 months for a median of 4 radiofrequency ablation sessions versus 3. 4 independent baseline predictors of poor response were identified. Active reflux esophagitis, endoscopic resection scar regeneration with Barrett's epithelium, esophageal narrowing pre-RFA, and years of neoplasia pre-RFA. Conclusions. Patients with a poor initial response to CRFA have a lower ultimate success rate for complete response neoplasia, complete response for intestinal metaplasia, require more treatment sessions, and a longer treatment period. A poor initial response to CRFA occurs more frequently in patients who regenerate their endoscopic resection scar with Barrett's epithelium, and those with ongoing reflux esophagitis, neoplasia in Barrett's esophagus for a longer time, or a narrow esophagus.